Welcome. I hope your day is going great. We're going to be discussing pharmacokinetics in this presentation. As discussed in the presentations of drug therapy in older adults and pediatrics, the pharmacokinetics change or evolve over the lifespan. Gender also significantly impacts a drug's pharmacokinetics. Pharmacokinetics is the study of drug movement throughout the body. It is what the body does to the drug. It entails the processes of absorption, distribution, metabolism, and excretion. Absorption is defined as the movement of a drug from its site of administration into the blood. Distribution is defined as drug movement from the blood to the interstitial space of tissues and from there into the cells. Metabolism is also called biotransformation, and it's defined as enzymatically mediated alteration of drug structure. Excretion is the movement of drugs and their metabolites out of the body. The combination of metabolism and excretion is called elimination. All four phases of pharmacokinetics, absorption, distribution, metabolism, and excretion, involve drug movement. Remember, kinesiology is the study of movement. Remember that drugs work at the cellular level. They must be able to be absorbed and distributed to reach the cells, and then must be able to enter and exit the cell. This is just a diagram of the four processes of pharmacokinetics. During absorption, the drug must find a path to the bloodstream to arrive at the target tissue. This usually means that the drug must cross several biologic membranes in the GI tract and blood vessels. There are three ways that drugs cross membranes. Only very small molecules can cross cell membranes through channels and pores. These channels and pores are specific for certain molecules such as sodium or potassium. Transport systems are carriers that move drugs from one side of the cell membrane to the other side and are selective. Whether a transporter will carry a particular drug depends on the drug's structure. P-glycoprotein is one such transport system and will be discussed on the next slide. The most common method to cross cell membranes is direct penetration of the membranes. P-glycoprotein is a transmembrane protein that transports a wide variety of drugs out of cells. In the liver, it transports drugs into the bile for elimination. In the kidney, it pumps drugs into the urine for excretion. In the placenta, it transports drugs back into the maternal blood, and in the brain, it pumps drugs into the blood to limit drugs' access to the brain. For most drugs, movement throughout the body is dependent on the drug's ability to penetrate membranes directly. Most drugs are too large to pass through channels or pores. Because of their selectivity, most drugs lack transport systems to help them cross all of the membranes that separate them from their sites of action, metabolism, and excretion. Remember back in Chem 101 when you were taught that the principle of like dissolves like? Keeping the structure of the cell membrane in mind, which is two layers of phospholipids with long hydrophobic tails on the outside,
you can infer that drugs that are lipid soluble will pass through the membrane. Polar molecules like water and ions are not lipid soluble.
Okay, we're going to go over a few of the factors influencing a drug's absorption. So, first is rate of dissolution. The faster a drug dissolves, the faster it can be absorbed, and the faster the effects will begin. What can you teach the patient that would increase dissolution? A couple of things that I can think of are taking the drug on an empty stomach with a full glass of water, such as with levothyroxine, or chewing the drug, such as when taking an aspirin when experiencing an acute MI. The dosage form of the drug. Obviously, some drugs are coated or formulated for slow absorption to decrease the number of doses needed in 24 hours. The presence or absence of food in the stomach. Depending on the drug, the presence of food can help absorption or decrease it. We most often think about food decreasing absorption, such as with iron, levothyroxine, or protein pump inhibitors. It isn't often that I find a drug that is better absorbed with food. The absorption of lapitinib, which is Tykerb, Tykerb, however, is increased by 325% if taken with fatty food and by 167% if taken with low-fat food, compared with taking the medication on an empty stomach. The surface area. The larger the surface area equals faster absorption. What's the implication for drug absorption of an oral preparation for a patient with short bowel syndrome or after small bowel resection for Crohn's disease? Obviously, there is less small bowel for absorption, and the patient may need a larger dose. Blood flow. The greater blood flow at the site of drug administration causes faster absorption. Strenuous exercise will divert blood flow to skeletal muscles and away from the GI viscera. Will this speed up or slow down drug absorption from the GI tract? It will obviously slow drug absorption that is taken orally. Lipid solubility. Drugs may carry an electrical charge like ions in the body. Such drugs with an electrical charge are usually very water soluble. Other drugs not containing an electrical charge are lipid soluble. Since the cell membrane consists largely of lipids, which type of drug do you think will pass through the cell membrane most readily using only the process of diffusion? High lipid solubility of the drug increases the permeability of the drug across cell membranes. pH partitioning. A drug that will ionize in the blood and not at the site of administration will absorb more quickly. Since electric charge decreases the membrane permeability of substances, once an acid enters a basic fluid and becomes electrically charged, then it cannot escape that compartment with ease and therefore accumulates, and vice versa with bases. For drugs which are weak acids or bases, the pH of the GI tract fluid and the pH of the bloodstream will control the solubility of the drug and thereby the rate of absorption through membranes lining the GI tract. There are some drugs labeled to take with food to avoid GI upset, such as amoxicillin clavulanate, NSAIDs, and iron forms. With iron, recognize that there will be some iron dose lost when taken with food, although it is best taken on an empty stomach, but many will not tolerate it on an empty stomach. Besides preventing an upset stomach, drugs may be taken with food to enhance drug absorption, such as with nitrofurantoin, where the amount of drug absorbed is 2 to 4 times due to delayed emptying by allowing more time to dissolve. Some drugs taken with food minimizes the risk of an adverse effect, such as with carvedilol. Taking the immediate release form with food slows absorption and minimizes risks of orthostasis.
I'm not going to review the methods or routes of administration, as you are all RNs and should know this. Enteral absorption goes through some portion of the GI tract. All routes of administration not involving the GI tract are considered parenteral. I didn't realize the definition of parenteral absorption. Parenteral routes include inhalation, all forms of injection, topical, and transdermal administration. Obviously, in primary care, we do not use the intravenous route, but all of the other routes are commonly used. The first pass effect is a type of pre-systemic metabolism. The blood flowing around the intestines does not go directly back to the systemic circulation, but instead it enters the portal circulation. Portal circulation goes to the liver before returning to the general circulation. This allows the liver access to a drug before it reaches the systemic circulation and the target tissue. Since the liver is the main site for metabolism, this first pass effect allows the liver to metabolize much of a drug before it reaches the site of action. First pass effect applies primarily to medications absorbed via the small intestine, where most oral medications are absorbed. The extent of first pass metabolism differs in different drugs. Drugs that are metabolized extensively are either given in higher doses or by a different route. For example, testosterone is usually given topically in gel form, as it is almost totally metabolized by the liver if taken orally. The same occurs with lidocaine. As another example, metoprolol, 50 to 100 milligrams, is a normal oral dose. When the same medication is given IV, the dose is only 5 to 15 milligrams. Alternative routes of administration like suppository, intravenous, intramuscular, inhalation aerosol, transdermal, and sublingual avoid the first pass effect because they allow drugs to be absorbed directly into the systemic circulation. All drugs absorbed from sites along the GI tract, including the stomach, small and large intestine, but not the oral mucosa or distal rectum, must go through the liver via the portal vein on their way to the heart and then the general circulation. For some drugs, passage is uneventful. Again, others undergo extensive hepatic metabolism, and still others undergo enterohepatic recirculation, a repeating cycle in which a drug moves from the liver into the duodenum via the bile duct, and then back to the liver via the portal vein.
Here's a 62-year-old woman with long-standing hypothyroidism. She's been on levothyroxine 0.1 milligrams daily, and her previous TSH was 1.2 micrograms per milliliter, which is within normal limits. She was placed on iron after significant intraoperative bleeding. Now her TSH is 10.3 micrograms per milliliter. What happened? Taking iron at the same time as levothyroxine causes an inactive compound to form. This is called chelation. Chelation in the intestinal tract is a cause of numerous interactions between drugs and metal ions. In this example, levothyroxine is a chelator of iron. Likewise, taking levothyroxine with calcium in milk products, as well as the others listed here, will do the same. This decreases the amount of levothyroxine that is active, and the TSH will rise as the levothyroxine levels drop. Levothyroxine should be separated from iron by at least 4 hours, and it should be taken on an empty stomach at the same time each day. Here is a 48-year-old woman with iron deficiency anemia. She is taking oral ferrous sulfate. She develops, however, a UTI. She is placed on oral ciprofloxacin. She remains symptomatic at 72 hours into treatment. During this time, the results of her urine culture show growth of E. coli that is sensitive to ciprofloxacin. What happened here? The dose of any floxacin is reduced by around 70% when taken with metals such as iron, calcium, which is potentially with dairy products, magnesium, and aluminum. All floxacins need to be separated by at least 4 hours from any metals or dairy products.
Distribution involves the drug being carried to the tissues, exiting the vascular system, and entering the cells. There are several factors that affect distribution. Blood flow to tissues is important. An abscess has no internal blood vessels. Therefore, because abscesses lack a blood supply, antibiotics cannot reach the bacteria within. Accordingly, if drug therapy is to be effective, the abscess must usually be surgically drained first. Solid tumors have a limited blood supply. Although blood flow to the outer regions of tumors is relatively high, blood flow becomes progressively lower toward the core. As a result, it may not be possible to achieve high drug levels deep inside tumors. If you have ever worked in surgery, you will often see that the centers of tumors are necrotic. Most capillary beds offer no resistance to drugs exiting them because in most tissues, drugs can leave the vasculature simply by passing through pores in the capillary wall. Because drugs pass between capillary cells rather than through them, movement into the interstitial space is not impeded. The term blood-brain barrier refers to the unique anatomy of capillaries in the central nervous system. There are tight junctions between the cells that compose the walls of most capillaries in the central nervous system. These junctions are so tight that they prevent drug passage. Consequently, to leave the blood and reach the sites of action within the brain, a drug must be able to pass through cells of the capillary wall. Only drugs that are lipid soluble or have a transport system can cross the blood-brain barrier to a significant degree. The blood-brain barrier may become less effective with aging. The membranes of the placenta separate the maternal circulation from fetal circulation. However, the membranes of the placenta do not constitute an absolute barrier to the passage of drugs. There are risks with drug transfers such as birth defects, including mental retardation, gross malformations, and low birth weight. Another risk is the mother's use of habitual opioids with the resultant birth of a drug-dependent baby. Protein binding. A drug that is highly bound to protein becomes inactive, unavailable for binding to receptors or exerting therapeutic effects. Because albumin is too large to leave the bloodstream, drug molecules that are bound to albumin can't leave either. Unbound, or the free drug, is able to cross plasma membranes and bind to receptors, producing therapeutic effects. Protein binding also may affect elimination. Only unbound drug is filtered at the glomerulus, so protein binding may slow elimination and prolong half-life. The percentage of drug that remains free and available for binding depends on the amount of plasma protein available, which differs among patients depending on their medical conditions. Some drugs must enter cells to reach the site of action. Many drugs produce their effects by binding with receptors on the external surface of the cell membrane. These do not need to cross the cell membrane to act, but most drugs must enter cells to undergo metabolism and excretion.
Drug metabolism is also known as biotransformation, and it's defined as the enzymatic alteration of drug structure. Its primary function is to allow for urinary excretion of drugs. Most drugs are designed to be lipophilic to allow for absorption and cell membrane penetration. Drugs must be changed to a hydrophilic metabolite to allow for urinary excretion. Drug metabolism also allows a prodrug to be transformed into an active metabolite. A prodrug is inactive upon administration, but then undergoes conversion to its active form through metabolism. Metabolism most often takes place in the liver and to a lesser extent in the kidneys and lungs, GI tract, and skin. We will be talking about the cytochrome P450 system in another lecture.
There are two phases of metabolism. Most drug metabolism that takes place in the liver is performed by the hepatic microsomal enzyme system, also known as the cytochrome P450 system. Again, I have a separate lecture on this system and its importance. Phase 1 metabolism involves chemical reactions such as oxidation, which is the most common, reduction, and hydrolysis. There are three possible results of phase 1 metabolism. The first option is that the drug becomes completely inactive. In other words, the metabolites are pharmacologically inactive. The second option is one or more of the metabolites are pharmacologically active, but less so than the original drug. And then the third option is the original substance is not pharmacologically active, but one of its metabolites is. The original substance is called a prodrug. Phase 2 metabolism involves reactions that chemically change the drug from phase 1 metabolites into compounds that are soluble enough to be excreted in the urine. In these reactions, the molecule, or drug, is attached to an ionizable grouping. This is called conjugation, and the product is called a conjugate. Metabolites formed in phase 2 are unlikely to be pharmacologically active.
The most important result of drug metabolism is the promotion of renal drug excretion. The kidneys are the major organs of drug excretion, and are unable to excrete drugs that are highly lipid soluble. So, metabolizing lipid soluble drugs into more water soluble forms can increase renal excretion of many drugs. Most commonly, drug metabolism inactivates active drugs. In addition, metabolism can increase the effectiveness of some drugs. For example, metabolism converts codeine into morphine, which has much greater analgesic activity than codeine. Metabolism can activate prodrugs. The advantages of using a prodrug is that it improves absorption from the site of administration, increases the duration of action of a drug that is rapidly eliminated, reduces adverse effects of the drug, better patient compliance as some patient might not like the otherwise bad smelling or bad tasting active drug, improved bioavailability of the drug. A successful example of the prodrug approach is levodopa in treatment of Parkinson's disease. Levodopa can cross the blood-brain barrier and convert into the active therapeutic dopamine, which itself cannot cross the blood-brain barrier. When the liver converts drugs into inactive forms, toxicity may be increased or decreased. The liver is meant to detoxify, but metabolism can convert safe drugs into forms that are toxic, such as with the example of acetaminophen being converted into a hepatotoxic metabolite that causes injury when acetaminophen is taken in overdose. If the liver is diseased, there is a variable impact on drug biotransformation. Drug levels will be increased if the drug needs to be biotransformed into the liver prior to excretion by the kidneys. For example, opioids, benzodiazepines, NSAIDs, and diuretics need to be altered to be water soluble for renal elimination. Unfortunately, unlike the GFR, there is no particular hepatic marker to advise when the liver is unable to do this biotransformation. Drug levels can be decreased if a prodrug is ingested. We will talk more about this later, but a prodrug is an inactive and must be activated by the liver for the drug to exert its effect. Codeine is an inactive drug that is transformed to morphine in the liver. Similarly, enalapril is inactivated in the liver. If the liver is failing, it is unable to activate these drugs effectively, if at all, and the drug levels are suppressed.
Excretion is defined as the removal of drugs from the body. Drugs and their metabolites can exit the body through urine, sweat, saliva, breast milk, or expired air. First, glomerular filtration removes drugs from the blood and excretes them in the urine. As blood flows through the glomerular capillaries, fluids and small molecules, including drugs, are forced through the pores of the capillary wall. Drugs bound to protein are not excreted as they are too large. Second, at the distal tubule, drug concentrations in the blood are lower than drug concentrations in the tubule. This concentration gradient acts as a driving force to move drugs from the lumen of the tubule back into the blood. Passive tubular reabsorption allows lipid-soluble drugs back into the blood, but polar and ionized drugs remain in the urine. Third, with active transport, the tubular pumps for organic acids and bases moves drugs from the blood to the urine.
If there is renal disease, the renally eliminated drugs are elevated. As examples, we have ciprofloxacin and levofloxacin that would need renal dosing in renal failure. Moxifloxacin is excreted fecally and is not impacted by renal failure.
Drugs entering the hepatic circulation may also enter the bile and be excreted into the duodenum and small intestines. Depending on the chemical properties of the drug, it may then be reabsorbed from the small intestine and recirculated throughout the body. And that's called enterohepatic recycling. Those drugs that are not reabsorbed will pass through the large intestines and be excreted in the feces. The lungs are the major route by which volatile anesthetics are excreted. Alcohol is partially eliminated by this route. Small amounts of drugs can appear in sweat and saliva. These routes have little therapeutic or toxicologic significance. They are considered secondary processes for drug excretion. The minimum effective concentration, or MEC, is defined as the plasma drug level below which therapeutic effects will not occur. Hence, to be a benefit, a drug must be present in concentrations at or above the MEC. Toxicity occurs when the plasma drug levels climb too high. The plasma level at which toxic effects begins is termed the toxic concentration. Doses must be kept small enough so that the toxic concentration is not reached. As indicated in the figure, there's a range of plasma drug levels falling between the MEC and the toxic concentration, which is termed the therapeutic range. When plasma levels are within the therapeutic range, there is enough drug present to produce therapeutic responses, but not so much that toxicity results. The objective of drug dosing is to maintain plasma drug levels within the therapeutic range. The width of the therapeutic range is a major determinant of the ease with which a drug can be used safely. Drugs that have a narrow therapeutic range are difficult to administer safely. Conversely, drugs that have a wide therapeutic range can be administered safely with relative ease. The therapeutic range is quantified or measured by the therapeutic index. Understanding the concept of therapeutic range can help you be a better healthcare provider, because drugs with a narrow therapeutic range are more dangerous than drugs with a wide therapeutic range. Patients taking drugs with a narrow therapeutic range are the most likely to require intervention for drug-related complications. The healthcare provider who is aware of this fact can focus additional attention on monitoring these patients for signs and symptoms of toxicity. Drugs with a narrow therapeutic index include warfarin, levothyroxine, carbamazepine, digoxin, lithium carbonate, and phenytoin, and theophylline. Drug levels rise as the medicine undergoes absorption. Drug levels then decline as metabolism and excretion eliminate the drug from the body. Because responses cannot occur until plasma drug levels have reached the MEC, there is a latent period between drug administration and the onset of effects. The extent of this delay is determined by the rate of absorption. The duration of effects is determined largely by the combination of metabolism and excretion. As long as drug levels remain above the MEC, therapeutic responses will be maintained. When the levels fall below the MEC, therapeutic responses will stop. because metabolism and excretion are the processes most responsible for causing plasma drug levels to fall. These processes are the primary determinants of how long drug effects will persist. When a drug is taken, the combination of metabolism and excretion will cause the amount of drug in the body to decline. The half-life of a drug is an index of just how rapidly that decline occurs for most drugs. Drug half-life is defined as the time required for the amount of drug in the body to decrease by 50%. This half-life can range from a few minutes or a week or more, depending on the drug. In the half-life, a percentage, not a specific amount of drug, is lost during one half-life. The half-life tells us that no matter what the amount of drug in the body may be, half or 50% will leave during a specified period of time, the half-life. The actual amount of drug that is lost during one half-life depends on just how much drug is present. The more drug in the body, the larger the amount lost during one half-life. The half-life determines how often the drug needs to be repeated to maintain the drug level in the therapeutic range. Repeated doses of the same drug will cause the drug to build up in the body until a plateau has been achieved. If a second dose of the drug is given before all of the prior dose has been eliminated, total body stores of that drug will be higher after the second dose than after the first one. As additional doses are administered, drug levels will climb even higher. Plateau will be reached in approximately 4 half-lives. The drug will continue to accumulate until a state has been achieved in which the amount of drug eliminated between doses equals the amount administered. When the amount of drug eliminated between doses equals the dose administered, average drug levels remain constant and plateau will have been reached. In opposition, 94% of the drug in the body will be eliminated in about 4 half-lives. And some sources do say 4 to 5 half-lives on both sides, on reaching plateau and elimination from the body. In summary, medications are prescribed to alleviate symptoms, cure disease, or prevent severe morbidity or mortality. Underpinning the treatment process is the intricate relationship between the body and the medications. Practitioners must be aware of the effect of pharmacokinetics, the movement of the drug through the body, and the pharmacodynamics, how the drug affects the body, when prescribing drug therapy for patients. We will be talking about pharmacodynamics in the next lecture. I hope that you have a great week.